Hi class, I'm Dr. Five. Welcome. We are going to cover today some structure and function of the digestive system. Let's start out with the GI tract. This consists of the mouth, esophagus, stomach, small intestine, large intestine, the rectum, and the anus. And there are digestive processes going on here. We have the ingestion of food, the propulsion of food and waste, secretion of mucus, water, and enzymes, mechanical, chemical, and absorption of digestive and digestion of food particles, and the elimination of waste products by defecation. The mouth consists of salivary glands, which we have salivary A amylase or alpha amylase, which is talin, and this initiates the carbohydrate digestion in the mouth and the stomach. The esophagus, it's a muscular tube, and this conducts substances from the oropharynx to the stomach. The stomach stores food during eating, secretes digestive juices, and it mixes food with juices and propels partially digested food, known as chyme, into the duodenum. Gastric motility. This increases with the initiation of peristaltic waves, and they sweep over the body of the stomach towards the antrum. Gastrin and motilin, these are small intestinal hormones, and the vagus nerve, they increase contraction by making the threshold potential of muscle fibers more negative. Sympathetic activity and secretin, which is a small intestine hormone, are inhibitory, and they make the threshold potential more negative. The rate of peristalsis is mediated by pacemaker cells that initiate a wave of depolarization, which moves from the upper part of the stomach to the pylorus. Now, gastric emptying that takes about 3 to 6 hours, and the rate depends on the volume, the osmotic pressure, and chemical composition of the contents. Gastric secretion. Now, this is stimulated by eating. The stomach produces large volumes of gastric secretions. There's specialized cells located throughout the gastric mucosa that produce mucus, acid enzymes, hormones, intrinsic factor, and gastropherin. Now, intrinsic factor is important because this is necessary for the absorption of B12. Gastropherin, that facilitates the small intestinal absorption of iron, iron. Parietal cells or oxytonic cells, these secrete hydrochloric acid, intrinsic factor, and gastropherin. So these other factors, intrinsic factor, gastropherin, and our hydrochloric acid are coming from these parietal cells. Chief cells, these secrete pepsinogen, and they're an enzyme precursor that is readily converted to pepsin, which is a proteolytic enzyme in the gastric fluid. The pyloric gland mucosa and the antrum synthesizes and release hormone gastrin from the G cells, gastrin G cells. Enterochromin-like cells that secrete histamine, and D cells that secrete somatostatin. We have gastric hydrochloric acid, and the purpose of this is to dissolve food. This also acts as bactericidal, and it converts pepsinogen to pepsin. Acid secretion by parietal cells is stimulated by acetylcholine, gastrin, and histamine. And we have a mucosal barrier protecting the stomach. It protects the gastric mucosa from the digestive actions of acid and pepsin. And here's just a chart of the different cells and the substance secreted by those cells. Now, the small intestine, this is about 5 to 6 meters long. 3 segments to it. We have the duodenum, the jejunum, and the ileum. We have the ileocecal valve, which controls the flow of digested material from the ileum into the large intestine, and this prevents reflux into the small intestine. The peritoneum, this is a serous membrane that surrounded the organs of the abdomen and the lining of the abdominal pelvic cavity, which is known as the peritoneal cavity. There's absorption that occurs through villi, which are the functional units of the intestine. The large intestine, this is about 1.5 meters long, and this consists of the cecum, appendix, rectum, and anal canal. The cecum is a pouch that received chyme from the ileum. Now, the variform appendix, or just the appendix, this is an appendage that has little to no physiologic function. 4 different parts of the colon: ascending, transverse, descending, and sigmoid. As you can see here, ascending going up, transverse going across, descending down, and the sigmoid colon. Enteric nervous system regulates the motor and secretory activity independently of the extrinsic nervous system control. There's vagal stimulation, and this increases the rhythmic contraction of the proximal colon, and the gastrocolic reflex, which initiates propulsion in the entire colon. Intestinal bacteria, there's bile acid secretion, intestinal motility, and antibody production that suppress bacterial growth in the duodenum. The intestinal tract is colonized with E. coli, Clostridium welchi, and Streptococcus. Those are the normal flora found in the GI tract. Excuse me, I skipped one here. Okay, accessory organs of digestion. We have the liver. This is the largest solid organ of the body, in the body. We have the right and left lobes on the liver. Metabolic functions of the liver require a large amount of blood, and that blood is coming from the hepatic portal vein and the hepatic artery. Those are the blood vessels of the liver. Hepatocytes, these are the functional cells of the liver. Lipocytes, which are star-shaped cells that store lipids and including vitamin A. Kupffer cells, which are part of the mononuclear phagocyte system. Stellate cells, which contain retinoids or vitamin A, and these are contractile in liver injury. They regulate sinusoid blood flow. They may proliferate into myofibroblasts and participate in liver fibrosis. These remove foreign substances from the blood and trap bacteria. Then we have pit cells, which are natural killer cells. And we have the secretion of bile. The liver assists in intestinal digestion by secreting 700 to 1200 milliliters of bile per day. So that bile is helping with the intestinal digestion of food. Bile, this is alkaline. It's a bitter tasting yellowish green fluid, and it contains bile salts, cholesterol, bilirubin, electrolytes, and water. Bile salts are required for intestinal emulsification and absorption of fats. And bilirubin is the byproduct of destruction of aged RBCs or red blood cells. And this gives bile the greenish black color and produces yellow tinge in jaundice. Now in plasma, the bilirubin binds to albumin and is known as an unconjugated bilirubin. Unconjugated bilirubin moves from plasma and the sinusoids into the hepatocyte, where it joins the glucuronic acid to form conjugated bilirubin. So you have unconjugated bilirubin, conjugated bilirubin. Now, when conjugated bilirubin reaches the distal ileum and colon, it is deconjugated by bacteria and converted to urobilinogen. And this is reabsorbed and transported to the kidney, where it's excreted in urine as urobilin, and this gives urine the yellow color that it has. Moving on to the gallbladder. This is a sac-like organ that lies in the inferior surface of the liver. See, we're here, right here under the liver. Primary function is to store and concentrate bile between meals. The sphincter of Oddi is what controls flow into the duodenum, and it prevents reflux of duodenal contents into the pancreatobiliary system. Now, within 30 minutes of eating, the gallbladder begins to contract, which forces that stored bile through the cystic duct into the common bile duct, which you can see right here. The hormonal regulation of the gallbladder contraction is derived primarily from the release of cholecystokinin. The exocrine pancreas. This is a pancreas is about 20 centimeters long, and the head is tucked into the curve of the duodenum, and its tail is touching the spleen. This has endocrine and exocrine functions. I should have just had pancreas here. Sorry about that. The exocrine pancreas is composed of acinar cells that secrete enzymes and networks of ducts that secrete alkaline fluids with important digestive functions. Now, the pancreatic enzymes hydrolase proteins or proteases, carbohydrates or amylases, and fats, which are lipases. Pancreatic lipases hydrolyze triglycerides, cholesterol, and phospholipids to free fatty acids in the intestine. And secretin secretes bicarbonate-rich fluid that neutralizes chyme. Some different tests of digestive function. Testing might be done with radiography or imaging techniques such as X-ray, radionuclide, PET scan, MRI, CT scan, or ultrasound. The patient may need to have some stool studies done, gastric acid stimulation, manometry. There's breath tests, in particular for H. pylori, small intestinal bacterial overgrowth breath test. I had to do that test, and it was very involved. I had to breathe into test tubes every 15 minutes or so for a couple of hours. It was a very involved test. And then labs, different labs you might have done are the serum enzymes such as the ALT and AST, bilirubin, serum proteins, and different blood clotting functions. All right, so let's move on to some digestive alterations. Common disorder you're going to see, GERD, gastroesophageal reflux disease. This is where there's a reflux of acid and pepsin from the stomach to the esophagus that causes esophagitis. Different risk factors for that: obesity, hiatal hernia, or medications that relax that lower esophageal sphincter. This may be a trigger for asthma or chronic cough. You have a patient coming in with a chronic cough, this is one of the differential diagnoses that you need to look at, as if it's GERD. Physiological reflux, GERD doesn't cause symptoms sometimes. We also have NERD, which is a non-erosive esophageal reflux, which you have the same symptoms of reflux, but no esophageal mucosal injury. So it's a functional heartburn. Now, what clinical manifestations are we going to see in the patient with GERD? Heartburn, chronic cough, asthma attacks in patients with asthma, laryngitis may occur as well. The patient may have some upper abdominal pain, which usually occurs within about an hour of eating. Now, these symptoms can get worse if laying down. Important to sit up after a meal, kind of get that food moving so you're not having that food causing reflux back into the esophagus. Heartburn may cause chest pain. This can be something that can scare a patient thinking that they're having a heart attack. So it can cause chest pain. Alcohol or acid-containing food can cause discomfort. Spicy foods, drinking too much alcohol, in particular stuff like whiskey, wine, different things like that that can aggravate this. And there's also a condition, eosinophilic esophagitis, which is a rare idiopathic inflammatory disease of the esophagus, and this is associated with atopic disease. Now, GERD can happen in pediatric patients, and this is a normal physiologic reflux due to the neuromuscular control of the gastroesophageal sphincter being not fully developed yet. So children will usually outgrow this reflux. They just need to have that gastroesophageal sphincter just needs to mature a little more. This may be a factor in the stimulation of reactive airway disease and otitis media with effusion in kids. Clinical manifestations, about 85% of infants will vomit excessively in the first week of life. Other symptoms, by 6 weeks of age, the patient may have feeding difficulty, may refuse feeding, or may have failure to thrive. The vomiting may be forceful, so it's very important to differentiate this from pyloric stenosis, which is another disorder that we'll talk about a little bit later. And there is a risk for aspiration pneumonia when this happens, so it's something to be very cautious about. It can have chronic cough, wheezing, hoarseness, and recurrent pneumonia. That's more so in the older child or adolescent. This chart here shows the differences of what you might see in the infant and the older child or adolescents with GERD. Peptic ulcer disease, this is where there is a break or an ulceration in the protective mucosal lining, the lower esophagus, the stomach, or the duodenum. Risk factors, there is a genetic predisposition for it. H. pylori can cause this, excessive use of NSAIDs, excessive alcohol, smoking, pancreatitis, COPD, obesity, cirrhosis, or being over 65 years of age. This can be acute or chronic, and it can be superficial or deep. Now, duodenal ulcers, these occur with the greatest frequency than the other types. There's chronic intermittent pain in the epigastric area. This pain usually begins 30 minutes to 2 hours after eating when the stomach is empty. So the stomach, the food goes through, stomach is empty, and that's when the pain is usually occurring. Pain relieved by food or antacids. So there's that pattern of a patient having pain, then food or antacids can end up alleviating some of that pain, and then it goes into that cycle again, pain, food, and relief. All right, inflammatory bowel disease, some different types. There's ulcerative colitis, Crohn's disease, and irritable bowel syndrome that we're going to talk about. Ulcerative colitis, this is a chronic inflammatory disease that causes ulceration of the colonic mucosa, and it extends proximally from the rectum into the colon. This occurs most in patients 20 to 40 years of age. Risk factors, family history, Jewish descent, and it is more prevalent in white populations as well. This is less common in smokers, and there are dietary, infectious, genetic, and immunologic factors involved. The location of the lesions, these occur in the colon and the rectum, and there are no skip lesions. And I'll talk a little bit more about skip lesions in a few minutes. They can have fissures, abscesses, strictures, and obstructions, but these are very rare. And here you can see the different types of the type of areas of the colon that are affected with ulcerative colitis. Different clinical manifestations we're going to see with ulcerative colitis. They can have intermittent periods of remission and exacerbations. This can vary with the severity and the extent of the disease. Patients may have large volumes of watery diarrhea. And because there's mucosal destruction, the patient may have bleeding, cramping pain, or the urge to defecate. The patient may have frequent bloody diarrhea with purulent mucus. And this affects the innermost lining of the intestinal wall. May have extraintestinal manifestations such as cutaneous lesions, migratory polyarthritis, sacroiliitis, osteopenia, osteoporosis, or maybe even oral lesions. And here's just some different symptoms going on with ulcerative colitis. Now, Crohn's disease or Crohn disease, there's a granulomatous colitis, ileocolitis, or regional enteritis. This is an idiopathic inflammatory disorder. Now, this can affect any part of the GI tract, and this has skip lesions. And what are skip lesions? Well, as you can see here, there's parts that are not affected, and there's parts that are affected. So it skips this part where it's not affected, and it affects this part, skips this part where it's not affected. So those are skip lesions, and you're going to see those more with Crohn's disease rather than with ulcerative colitis. Now, the distal small intestine and the proximal large colon are most commonly affected, but it can affect the entire intestinal wall. So sometimes this can be difficult to differentiate from ulcerative colitis. Risk factors here, again, family history, smoking, Jewish ethnicity, those living in an urban area, age less than 40 years of age, and there's a slight predominance of this in women. Clinical manifestations, no specific symptoms other than irritable bowel for several years. And then patient may have abdominal pain, diarrhea, and passage of blood and mucus. Now in this one, fistulas, abscesses, strictures, and possible obstruction are common, whereas with ulcerative colitis, these were rare occurrences. Here's just a comparison of the two, again, with the skip lesions, unaffected, affected area, skips an area, affected area, and ulcerative colitis. And see, this is happening here in the small intestine as well. It can happen anywhere in the smaller, large intestines. And then ulcerative colitis happening just in the colon and no skip lesions. Now, diverticular disease of the colon, these diverticular are herniations or sac-like outpouchings of mucus through the muscle layer of the colon wall. So here's a little diverticula. Diverticulosis, which is asymptomatic diverticular disease, or we can have diverticulitis when there's inflammation, stuff getting caught in there causing inflammation and infection. Most common site affected is the left colon. Cause of this is unknown, occurs mostly in people age 60 and older, can come from a decreased dietary fiber intake, increased intracolonic pressure, abnormal neuromuscular function, or alterations in intestinal motility. Clinical manifestations may be vague or absent. Patient may have cramping in the lower abdomen, diarrhea or constipation, distension of the abdomen, flatulence, abscess formation can occur. Patient may have fever, leukocytosis, or a tender left lower quadrant. Uncomplicated diverticular disease, just going to treat with rest and antibiotics. Diet, you want to have patient increase fiber and make sure they're having adequate water intake. If there's severe complications, the patient may need to have surgical resection of the area done. Now, irritable bowel syndrome, this is a functional GI disorder that's characterized by pain and altered bowel habits. This is more common in women, younger, you're in youth and middle-aged. Anxiety and depression kind of go along with this. Pathophysiology, there's varying symptom presentation. Clinical manifestation, lower abdominal pain. You can have diarrhea prominent, where the patient has diarrhea most of the time, constipation predominant, or they can have alternating diarrhea and constipation. Patient can also have gas, bloating, nausea, fecal urgency, and a feeling of an incomplete evacuation of stool. Again, there's some symptoms there for that. Colorectal cancer, this is the third most common cause of cancer death. Median age for this, 69 years old. More common in Blacks worldwide. And the prevalence is highest in populations with high socioeconomic standards. This can be acquired or inherited, and there are environmental factors involved that can lead to colorectal cancer as well. Clinical manifestation depends on the location, size, and shape, and the metastasis of the lesion. And here it's showing the different stages of that growth of colon cancer and spreading to other organs, metastasizing. All right, alterations of digestive function in children. Disorders of the GI tract, we're going to look at some congenital impairment of motility where a patient may have a cleft lip or cleft palate. These are developmental anomalies of the first brachial arch. Most common, it's a multiple gene environment interaction. The maternal deficiency of B vitamins such as B6, folic acid, and B12, that can lead to these. Maternal smoking and alcohol use, maternal hyperhomocystinemia, and maternal diabetes mellitus. So oftentimes this is coming from different things going on with the mom. Genetic variations of interferon regulatory factor 6, fibroblast growth factor, and tumor growth factor alpha are all different issues with genetic variations. So together, these factors reduce the amount of neural crest mesenchyme that migrates into the area that will develop into the face in the embryo. And this can lead to feeding issues. The infant can have feeding issues with these disorders. Esophageal malformations, we have congenital malformations of the esophagus, thankfully are rare. Esophageal atresia, this is the esophagus, ends in a blind pouch, and is usually accompanied by a fistula between the esophagus and the trachea. So we can see that here. Pathogenesis of this is unknown. It arises from a defective differentiation as the trachea separates from the esophagus during the 4th and 6th weeks of embryonic development. There's defective growth of endodermal cells that leads to atresia. And there's other congenital anomalies are often present when a patient has this esophageal malformation. So we want to look at bacterial. There could be vertebral anomalies, anal atresia, cardiovascular malformations, TE fistula and or esophageal atresia, renal anomalies, and limb anomalies. So important things to also look for in patients with this disorder. Pyloric stenosis, this is obstruction of the pyloric sphincter. So this is one of the most common disorders of early infancy, and it affects infants ages 1 to 2 weeks or 3 to 4 months. This is more common in males, whites, and full-term infants. The cause is unknown, but increased gastrin secretion by the mom in the last trimester of pregnancy raises the risk of this happening. So between 2 to 3 weeks after birth, a previously thriving baby begins projectile, non-bilious vomiting after eating. Treatment with this is surgical. The patient will have to have a myotomy. And as you can see here, the comparison with the healthy pylorus, this is stenosis. This is too closed off. It's too narrow for anything to get through there. So that's why it has to be surgically repaired. Meconium ileus, this is a substance that fills the entire intestine before the baby is born. And this consists of intestinal gland secretions and also has some amniotic fluid in there. This normally passes during the first 12 to 72 hours after birth. Now, a patient may have a meconium ileus, which is an intestinal obstruction caused by meconium formed in utero. This can be caused by a lack of digestive enzymes during fetal life, albumin present, which is not normally a meconium, and this is associated with cystic fibrosis. Patient may have abdominal distension and vomiting. And in babies with cystic fibrosis, they may have tachypnea, intercostal retractions, and grunting respirations, as those areas of the body can be affected as well. And here's just showing the meconium ileus causing an obstruction there. Congenital aganglionic megacolon, also known as Hirschsprung disease. This is a functional obstruction of the colon that's caused by the absence of enteric ganglia along the variable length of the colon with inadequate motility. So here we have the ganglionic cells, which aid in motility of the colon. And with Hirschsprung's disease, there's no ganglion cells here. So there's motility isn't happening as much here. And this is a malformation of the parasympathetic nervous system. The most distal part of the rectum is always involved here. Symptoms, chronic constipation, because nothing can get through, nothing's moving through because of the absence of those ganglionic cells. Patient may have poor feeding, poor weight gain, and progressive abdominal distension, and then the neonate may have a delayed passage of meconium. Okay, acquired impairment of motility, we can have intusception, which is where there's telescoping or invagination of one portion of the intestine into the other. So you can see it happening here. Just goes right into that area. The ileum invaginates the cecum and part of the ascending colon by collapsing through the ileocecal valve. This can occur anywhere from the duodenum to the rectum. There's sudden onset of abdominal pain, colic, and flexes the knees. May have vomiting, normal stool, but then they might pass this current jelly stools, which is a combination of blood and mucus. So this is something, if you're looking at the stool, the current jelly stool is significant for that, which is blood and mucus in the stool. And they may have tender sausage-shaped abdominal mass that can be palpated. GERD, let's see, we already talked about this. I'll just go over this again. There's a return of the stomach contents into the esophagus due to that, the underdeveloped LES. Newborn's GERD is normal because that neuromuscular control of the gastroesophageal sphincter is not fully developed. This occurs frequently in preemies. Infants will vomit excessively in that first week of life, can have difficulty feeding, refuse feeding, and have failure to thrive. We have forceful vomiting, and again, must differentiate that from pyloric stenosis. And we do need to be cautious of that risk for aspiration pneumonia. More on cystic fibrosis, impairment of digestion, absorption, and nutrition. We'll just cover cystic fibrosis, meconium ileus at birth, like we talked about, Rectal prolapse, this should always prompt testing for cystic fibrosis. Now there's a pathophysiological triad. We have a pancreatic enzyme deficiency. There's an overproduction of mucus in the respiratory tract and the inability to clear secretions. And there's abnormally elevated sodium and chloride concentrations in the sweat. So it's important to remember you're going to have different things going on here. Pancreas involved, overproduction of mucus, so respiratory tract is involved, and the sodium and chloride concentrations in the sweat are going to be abnormally elevated. Now there's a chart in the textbook that goes over the pathophysiology, clinical manifestations and complications. You can read through that. A sweat test is done to aid in diagnosis, and the patient will need pancreatic enzymes due to this deficiency. More on the impairment of digestion, absorption, and nutrition. We have gluten-sensitive enteropathy. So we have celiac disease or celiac sprue. This is an autoimmune disease, correct my spelling error here, of small intestinal villus epithelium. There's issues with wheat, rye, barley, and oats. This has genetic, immune, and environmental factors involved. There's cellular immunity and humoral immunity, and T-cell mediated autoimmune injury to the intestinal epithelial cells. Diarrhea is an early sign. Also may have failure to thrive and anemia. The stools may be pale, bulky, greasy, and foul-smelling, and may contain oil droplets. Now we have severe acute malnutrition, kwashiorkor, which is nutritional edema, and marasmus, which these are the most common types of malnutrition. These are known collectively as severe acute malnutrition. The states of starvation are associated with food storages. Now with kwashiorkor, there's severe protein deficiency. Patient is going to have subcutaneous fat, hepatomegaly, and fatty liver. Now with marasmus, this is a severe deficiency in all nutrients as compared to kwashiorkor, where it's a protein deficiency. Marasmus, deficiency in all nutrients. Caloric intake is not sufficient to support fat synthesis and storage. So both of these affect growth, physical, mental, psychological development. There's muscle wasting, diarrhea, dermatosis, low hemoglobin level, and risk for infection. And here's the difference, as you can see, when you have that abdominal protruding abdomen, and this is because that subcutaneous fat is reserved. And here with marasmus, you have a shrunken abdomen because this is more of an overall nutritional deficiency, where this one is protein deficiency. A failure to thrive, inadequate intake, insufficient absorption, or excessive expenditure of calories. This can be caused by GERD, pyloric stenosis, gastroenteritis, cystic fibrosis, malabsorption syndromes, infection by intestinal parasites, congenital anomalies, very low birth weight, and chronic disease. All right, last one we're going to talk about here is disorders of the liver in pediatrics. These are disorders of biliary metabolism and transport. Neonatal jaundice is the physiologic jaundice or hyperbilirubinemia. This is usually transient. Okay, sorry about that. I had a phone call. I had to check. Okay, neonatal jaundice, physiologic jaundice, hyperbilirubinemia. This is usually transient. It's benign icterus that occurs in the first week of life in a healthy full-term baby. Now there can be pathological jaundice, which appears within 24 hours after birth. Risk factors for this: a fetal maternal blood type incompatibility, prematurity of baby, exclusive breastfeeding, delayed passage of meconium, and excessive birth trauma. Pathophysiology is interaction of factors. There's increased bilirubin production, impaired hepatic uptake, and delayed maturation of the liver conjugating mechanisms. Clinical manifestations: that yellowing of the skin, dark urine, light-colored stools, and weight loss. That's all I'm going to cover on gastrointestinal. Make sure that you're reviewing all of the chapters in the textbook, as you're responsible for all the readings. Please let me know if you have any questions or concerns. Thank you all and have a great day.